Assalamu alaikum. Today we are here again with the topic of ACS, and we will tell you about the ACS, the pathophysiology of the ACS, the high risk feature of the ACS, and actually ACS encompasses all like STEMI, non-STEMI, and unstable angina. So we will cover here the non-STEMI and the unstable angina, the risk stratification and the risk stratifying scores, and then the treatment and the strategies how to treat the non-ST ACS. So I think without wasting time, we need to start over here about ACS. Okay, first of all, I will, sorry, I was a bit hungry, that's why I'm eating the dry fruit. So sorry. First of all, we will do the pathophysiology. I will tell you about the pathophysiology of the ACS, and then we will move towards the approach, how to approach the ACS. So that is the same things which occur actually in non-ST ACS. Okay, so what is this? This is the same plaque, actually unstable plaque in non-ST ACS. Okay, and the non-ST ACS actually encompasses two things: the non-ST elevation MI and unstable angina. Okay, unstable angina. So the morphology and the characteristics of the plaque is actually unstable. That's why we encompasses this non-ST elevation MI as a non-ST elevation ACS. Okay, so what are the characteristics of this unstable plaque? That the capsule of this plaque is actually thin, as it was in ST elevation MI. So what happens here, if this thin capsule ruptures anywhere from here or here or here or here, it causes what? Again, the activation of the platelet system, the clotting system, where the platelets comes here and the GB, 2B3 causes morphological changes in the platelet, and the thrombus formation actually starts. What happens actually when this disruption, which actually causes three things, causes three things: the erosion and dissection causes what? This rupture of the plaque, capsule of the plaque, which is actually thin in the unstable plaque. So then second step would be here, like the thrombus formation, and then after thrombus formation there would be a vasospasm. So these three things could be together in the non-ST elevation MI, and it could be alone, like only erosion in the disease, only thrombus formation because of the any procoagulant state, and the only vasospasm in the presmental angina. So if this disruption causes infarction in the heart, it would be non-ST elevation MI. If this disruption occurs but this myocardial infarction yet to be done, okay, so it would be unstable angina. The only difference and the only borderline between the non-ST elevation MI and the unstable angina is the infarction of the myocardium, which actually give rises as the TROPS, the leakage of the biomarkers. So the additional features, the additional things which we would have in our patient with biomarkers, we conclude it and we diagnose it as a non-ST elevation MI. But if you get all the things of the non-ST ACS but not this, it means myocardial infarction yet to be done. Okay, so you will call it as a unstable angina, but you have to be very vigilant in these patients, because anytime they could be turned into non-ST elevation MI or might as a ST elevation MI. Okay, so because this is, and one thing more, in ST elevation MI there would be a complete occlusion of the artery because of this thrombus, but in non-ST elevation MI there would not be the complete occlusion but the partial occlusion. Only the partial occlusion of the artery causes what? Infarction. So this is actually the pathophysiology behind what? Behind your non-ST elevation MI. Okay. So yeah, I am eating